Okay, let's dive right into this explainer. And look, I have to start with a huge spoiler. I just passed my VBC exam. I am absolutely still riding the high of that achievement, and I just had to capture this moment. Let's rewind a bit. I've been an ER nurse for about 12 or 13 years, and a few years ago, I stepped into a vascular access role. Everyone before me was certified, but I hadn't taken a proctored exam in, well, years. I always told myself I wouldn't do it. I hated studying, I hated reviewing, testing, the whole shebang. But vascular access completely changed that. Once I started really digging in, reading the guidelines, watching videos, answering practice questions, something just clicked. It felt fluid. It felt natural. I went from dodging exams to becoming completely obsessed with learning absolutely everything I could. Because people who love vascular access, they really love it. They love the deep skill, the steadiness, the coordination, and the undeniable thrill of success. It takes time, but the ones who understand it absolutely thrive. So let's get into section 1, the high of mastery. Look at the contrast between where I started and where we are now. In my early ER days, we had this old mentality. We were hyper-focused on just getting the job done, right? Getting the labs, getting the meds, even if it meant painful blind sticks. But vascular access is different. It's not just about getting through the next hour. It's heavily focused on quality, longevity, and patient safety. Looking back now, I honestly cringe at some of the things we did in the ER. We totally meant well, but we just did not know what we did not know. We were doing AC sticks or bacillic and brachial attempts right next to arteries, causing these super painful pokes. True vascular access, though, it's about intentionally choosing a vein that will remain robust and functional for the patient's entire hospital stay. Moving on to section 2, decoding the secret language. I remember the first time I saw an ultrasound used for IV placement. I was a 1-year ER nurse, and my preceptor, this travel nurse who had worked literally everywhere, turned the machine on. To me, it just looked like black and white static, like some secret language I wasn't ready to decode. Fast forward 6 years, everyone was doing it, and I wanted to learn. When you finally decode that language, you visually ground your entire assessment. You start mapping optimal pathways, like the cephalic, bacillic, and median veins, intentionally avoiding areas of flexion. You're also assessing the true depth of the vessel, ideally looking for something between 0.3 and 1.5 centimeters deep. Now here is a massive rule for both clinical practice and, yes, the exam. The catheter-to-vein ratio must be 33% or less. To put that into perspective, if your vein is 4 millimeters across, your catheter shouldn't be more than about 1.3 millimeters. This isn't just a suggestion. It's mandated by guidelines to preserve blood flow around the catheter, which drastically reduces the risk of thrombosis. When I scan an arm now, I have an exact mental checklist. I am hunting for that perfect black circle. It needs to be compressible, non-pulsatile, round, and consistent. I check the length of the vein to make sure it stays robust for the entire catheter length. I also deeply consider skin turgor and tissue planes, especially in our older patients. Think about it. If the superficial skin moves but the deeper tissue doesn't, you need way more catheter purchase, or that line is simply going to pop out the second they move. Once I find that perfect vein, I prep the skin, regel the probe, center the vessel, and spray the skin refrigerant. Which brings us to section 3, choosing the right tool. My process has become incredibly intentional before I even touch a machine. I walk into a room and immediately ask, what is the plan? Which arm do they prefer? How do they sleep? Exactly what therapy are they here for? Are they getting surgery, short-term antibiotics, fluids? Matching the patient's actual life and therapy to the device is the absolute foundation of what we do. And this is where that deep clinical knowledge really comes in. A peripheral IV is fantastic for a few days of hydration, but pouring a vesicant into a peripheral vein, that's literally like pouring acid into a drinking straw. It destroys the vessel wall. For vesicants or TPN, you absolutely need the high blood flow of central access, like a PICC, to rapidly dilute those harsh medications. By the way, there is a massive misconception out there, both on the exam and on the hospital floor, regarding midlines. Let's clear this up right now. A midline catheter is not a short PICC. It is a peripheral device with a longer reach that terminates in the proximal arm, right beneath the axilla. It does not reach the central circulation, so it is definitely still inappropriate for vesicants, TPN, or chemotherapy. All right, let's jump to section 4, the perfect puncture. The guidelines strictly advocate for a new standard of care, and it's simple. No blind sticks. Using ultrasound guidance is essential. It prevents catastrophic complications like inadvertent arterial punctures or severe nerve damage. When you can see the anatomy in real time, you're protecting your patient from trauma that a blind stick simply cannot account for. The technique itself has this amazing visceral rhythm to it. Once you center the vessel, your approach is steeper than a blind stick, usually around 35 to 40 degrees. You puncture the skin, find that bright echogenic needle tip, and then it's a dance. Needle hand, probe hand. Needle hand, probe hand. You watch the vessel dip as you touch it, then gently walk the needle in until you see that bright dot perfectly inside the black circle. Most people think seeing that initial flash is the moment to just send it. It is not. This is a massive clinical pearl. You have to be patient. You keep alternating hands, lower your angle, and advance until at least 3/4 of the catheter is safely inside the vessel. Only then do you lay the probe down and thread. That's the technique that ensures longevity and prevents the line from failing a day later. Finally, Section 5, Beyond the Machine. Mastering the machine is really only half the battle. Communication is a clinical intervention in itself. When you walk into a room, patients are anxious. You must frame your interventions as solutions, not just tasks. Instead of saying, "I'm here to place a pick," explain it. Say, "Your care team wants to give you medications that are just too strong for the small, fragile veins in your hand, so we're going to use a larger vein to deliver them safely." Use the teach-back method, avoid medical jargon, and document absolutely everything as your legal shield. When you're teaching device care, use vivid, simple language with adult respect. I always tell patients your dressing should look like a clean window. No fog, no moisture, no lifting at the edges. You have to empower them. Explicitly tell them they are never a burden for speaking up, so they feel confident reporting any tightness, swelling, or redness right away. That empowerment is absolutely critical because early detection prevents disasters. If a complication like extravasation happens, where a vesicant leaks into the surrounding tissue, it can lead to severe tissue necrosis and blistering. If you or the patient notice swelling or fluid leakage, you must stop that infusion immediately and intervene. Bringing this all full circle, some people actively avoid learning ultrasound access because they don't want to be called everywhere to do the hard IVs. But that mindset completely limits your value. When I mastered this, eventually, the CT techs wouldn't even check the IV if I started it. They just take the patient straight to the scanner because if it was mine, it was good. When you learn this skill, you become more capable, more independent, and a vital advocate for your patients. You aren't waiting for someone else to be the hero. You are the hero. I know I've been rambling a bit today, but I really wanted to capture what this process, this passion, and this evolution feels like. So here is the question I want to leave you with. Will you remain a task doer, getting by on blind sticks and just hoping for the best? Or are you ready to stop avoiding the hard learning, master the secret language of vascular access, and become the precise, intentional clinician your patients truly need? Keep learning, keep advocating, and it will change your practice forever.